I'm going to talk today about the importance of the role of the nurse in the management of the patient with traumatic brain injury. These are my disclosures, same as I had yesterday. Nothing really that pertains to this talk. I have received some funding from Neuroptics, from the United States Department of Defense, and the Agnes Marshall Walker Foundation for my research. I don't think I'm going to wander into those areas today. Just as a reminder, yesterday I talked about nursing care of the patient in coma, and I discussed the cue response theory. I provided an explanation of how that works, and what I talked about yesterday is pretty important for what I'm talking about today. However, I'm not going to redo all of the stuff from yesterday, especially for those of you who are traumatized by my statistics lecture. I'm not going to give you a statistics lecture today. What I am going to talk about is more specific to traumatic brain injury. Just to be transparent, Pat Zrelak wrote an article that is free. This is a link to that article down here. If you want me to share the link at some point in time, you can email me. But this is an article on evidence-based care of nursing care of adults with severe traumatic brain injury. It's helpful for some kids, but this is just a summary of the evidence-based care. Let's talk about nursing. A lot of you are nurses. I hope a lot of nurses here, but I hope there's also some physicians, some pharmacists, and some therapists listening in. On the left-hand side of the screen, this is the nursing process that I grew up with as a nurse in 1980. It was assess, plan, implement, evaluate. That's the old version. The new version of the process is assess, figure out what's going on, diagnose, come up with a nursing diagnosis. Now, we're not diagnosing that the patient had an intracerebral hemorrhage. We are diagnosing that the patient had a change in neurological function, right? Nursing diagnosis. Then we plan, we figure out what are our goals? What do we want to do for this patient? What outcomes do we want to see? We implement a set of nursing actions, nursing interventions. After implementing them, we evaluate. Did they work? Right? My goal was that the patient's blood pressure would come down. My intervention was to get the patient to relax, stop jumping around in the room. And then I evaluate this by looking at his blood pressure, and sure enough, his blood pressure has come down. Yay. I continue to assess. This is cyclical. One of the tenets of nursing that I have always put forth, really important to me, nurses are the eyes and the ears of the medical team. Yesterday, I spoke that because the physician takes care of many patients, she or he can only be in one room at a time. So they get about 30 minutes a day with the patient. Because as an ICU nurse, I have one or two patients, I can be in that patient's room all day long, and often I am. On any given day, on average, a nurse will do 3,081 different things. Most of these things are done more than one at a time, simultaneous. Now, we can't space these out either. We can't say, well, I have to do 3,081 things. I'll do 1, 2, 3, 4, and I'll have them equally spaced out, because many of these things are in response to events. So we might have to do 300 things between 8 and 8:30, and then have not much to do, maybe only one thing, until 9 o'clock. They're not equally spaced out. Also, look at the bottom. Across the globe, 35% of the nurses who are working have less than 2 years experience. Not as much of an experienced group as we used to have. I want to focus in for now on these 3 points. 3,000 different things. Half of them are done all at the same time, and you can't space them out. I'm going to do this by talking about 2 minutes of my life as a nurse. For those of you who are physicians or doctors, maybe you've never had a chance to do this. Nurses, I think you'll understand this. Here's 2 minutes of my life. I walk into a room because it's time to check the patient's vital signs. I'm getting the patient's medicines ready, and the family is new to this patient with traumatic brain injury, so I'm going to teach them while I'm getting my medicines ready. I'm teaching them about traumatic brain injury, but all that they want to know is where can they get a good cup of coffee? As I'm doing this, I look at the monitor and the intracranial pressure is going up to like 20. So I continue to talk to them. I turn the stopcock on the monitor to let some cerebral spinal fluid out. I put a quick page into the pharmacy to ask for hypertonic saline. As I'm telling them where they can get coffee down in the cafeteria, I turn the EVD drain off so I can evaluate if the intracranial pressure has come down. As I'm looking at the waveform and documenting that my pressure 1 is lower than P2, P2 is elevated non-compliance, I'm thinking, the family asked more questions about what are the cafeteria hours because they don't recognize that this person's going to die if I don't do something right away. Pharmacy shows up with hypertonic saline. I'm hanging that, and I'm looking out in the hallway because my patient slid down in bed, and now they're laying in bed like this, and they're crunching off their carotids. I see a resident walk by in the hallway while I'm doing the 23%, and I yell to the resident, come into the room to help me. He's scared to death and says he's going to help me by finding someone else to help me. But first, what's this patient's name again? So I tell them the patient's name. I note my intracranial pressure is coming down, but I still haven't suctioned the patient. Sooner or later, I have to time the suctioning. But before I suction the patient, I want to get the patient up in bed so his head of bed is elevated. I asked the resident, can you help scoop me up in bed? The resident said, no, he doesn't do that. He's a brain surgeon, and he's going to leave and go get some help from somewhere else. Right? So I'm trying to decide, do I suction now? Do I wait for the blood pressure to come down or the ICP to come down? I had increased my sedation earlier, and now I notice my blood pressure is dropping. So I also have to figure out, do I start the patient on phenylephrine to bring their blood pressure up, or do I decrease the propofol so that stops causing the blood pressure to go down? And I still got to get this patient up in bed. Their arterial line waveform is bad. Now, in that 2 minutes, look at all of this craziness that I'm dealing with. And that is every nurse, every patient, every day. 3,000 decisions a day that our nurses are making. When we are caring for a patient with traumatic brain injury, we are making 3,000 decisions a day. So the nursing process is not assess, plan, implement, evaluate, diagnose. It's like plan, assess, plan again, evaluate, plan again, assess again, evaluate, plan again, implement. I mean, it's all over. So when we talk about this session is how important is it for nurses to take care of patients with traumatic brain injury? How important is my role as a nurse? Well, it's really darn important, because without me, this system collapses. If you don't have a nurse making 3,000 decisions a day, Who's going to make those? It's not that the doctor's not smart enough. It's that the doctor isn't there. I'm there. Someone has to do all this work. Now, I'm okay if you want to switch roles. I'll do the surgery. You wipe up their butt. We can switch roles. You're perfectly capable of it. But this is my role. Someone has to be in the right place at the right time and do things in the right sequence. I think I have established, just on my 2-minute example, there's a lot of things that nurses do. And 3,000 decisions. But how does this relate to traumatic brain injury? Let's use the example of intracranial pressure. And I want to talk about ICP because ICP is as relevant to traumatic brain injury as coffee is to breakfast. You cannot have one without the other. If you're talking about coffee, it's coffee and breakfast, ICP and TBI. And if you're going to talk about ICP, you probably are going to talk about the Monroe Keely hypothesis. We've talked about Monroe Keely since I was 20 back in 1980. This article by Dr. Monroe Keely has been cited hundreds of times, thousands of times. If you Google the Monroe Keely doctrine or Monroe Keely hypothesis, you get 23,000 hits. But who are these people? Who is Monroe? Who is Keely? Some people call him Kelly. Who are Monroe and Kelly? Monroe Keely. Dr. Monroe was Dr. Alexander Monroe, and in 1783, he wrote this paper called Observations on the Structure and Functions of the Nervous System, and he drew some very pretty pictures. This was published in 1783. This is one section of that article where he writes, "For being enclosed in a case of bone, the blood must continually flow out of the veins to give room for more blood to come in." So he talked about the skull, right? The skull being this case of bone. And he talked that you had to get blood to come out to make room for other blood to come in. Notice Dr. Monroe never talked about cerebral spinal fluid, and he never talked about pressure. He barely talked about brain. He mostly talked about blood and bones. 40 years later, 40 years, Dr. Keely, George Keely, wrote another paper. The title of his paper, I got to take a big deep breath. The title of his paper was An Account of the Appearances Observed in the Dissection of Two of the Three Individuals Presumed to have Perished in the Storm of the Third, and whose bodies were discovered in the vicinity of Leith on the morning of the 4th November, 1821, with some reflection on the pathology of the brain. Part 1. In 2020, we would call this a case study because what Dr. Keely did is 3 years before this article came out, three soldiers from a ship got lost in a storm and washed ashore. One of them was so badly decomposed, he didn't deal with them. The other two, he cut their heads off and carried the heads into a lab where he did some studies. And when he was doing those studies, he decided that if what his observations are true, not that they are true, but if they are true, then it does not appear very conceivable, very likely, how any portion of the circulating fluid, the blood, can ever come out of the skull without other blood coming in. In other words, he said you can't take blood out without blood coming in. Right? Now, Monroe said you have to have blood go out in order for stuff come in. This is similar. And Dr. Keely studied under Dr. Monroe. But all he really did was he discovered vacuum. You've all taken a bottle and turned it upside down, and if it's got a small hole, this all creates a vacuum and the water doesn't spill out. It looks like magic. Well, let's take it back a step first, because neither Keely nor Monroe talk about cerebral spinal fluid. Now, cerebral spinal fluid had been sort of discovered. In 400 BC, Hippocrates talked about there was some fluid in the brain that was like water. It was like water. But he was talking about congenital hydrocephalus. And then in 2000 AD, Dr. Galen finds there's excremental fluid that's purged through the nose, that he hypothesizes comes from the ventricles. And then for about 2,000 years, nothing. Nobody talks about cerebral spinal fluid. During the Dark Ages, it's all but disappeared, because the only way we do studies of the brain is we cut the head off, right? And we carry the head into the lab. And when you do that, all the cerebral spinal fluid leaks out. So nobody knew about it. However, in 1824, after George Keely published his article, Dr. Magendie was doing some experiments, and he discovered brain water, cerebral spinal fluid, which he said is secreted by the pia mater. No, it's not. And it drains out through a hole that no one has yet discovered. Well, it turns out he was wrong on that too. But he wasn't sure about his results, so he waited a year to publish. He didn't publish until a year after Monroe, or 40 years after Monroe, and a year after Keely. So when we talk about the Monroe Keely doctrine having cerebral spinal fluid as part of the formula, we're wrong. Dr. Monroe died without ever knowing about cerebral spinal fluid. Keely published. Now, this is where it gets fun. There was this guy named Swedenborg who in 1744 had discovered cerebral spinal fluid, but he never published his paper. Instead, his great-grandson published the Swedenborg paper 140 years after Swedenborg discovered it. So that couldn't be part of the formula. 4 years after Keely, Dr. John Abercrombie publishes a paper called Pathological and Practical Research on the Disease of the Brain and Spinal Cord. And in this paper, he talks about how Monroe and Keely had synthesized ideas that drove his way of thinking. He gives credit to his doctrine being based on Monroe Keely. So it's kind of not the Monroe Keely, but it's kind of Abercrombie, right? But then later, Dr. Burrows tests this hypothesis and realizes that it was just blood and brain at that point, only blood and brain, and he pulls in this cerebral spinal fluid stuff, and he says that if you get rid of the cerebral spinal fluid after someone dies, you make more room for blood. So he changes the formula. Dr. Burrows changes the formula from the intracranial volume. Notice we're not talking about pressure. Intracranial volume is made up of blood and brain and CSF. So he adds three things. If we look at our timeline, it's about 63 years after Dr. Monroe published that we get the blood plus brain plus CSF. This timeline continues to grow because in 1890, Dr. Keene performed the first EVD. In 1891, Dr. Quincke uses a pipette and a lumbar puncture to measure the pressure. In 1903, Cushing gets famous because he talks about a triad of things that if you recognize this change in blood pressure, heart rate, and breathing, if you recognize this triad, it means the brain is pushing down. There's too much pressure. But Cushing never measured pressure. He didn't measure ICP there. In fact, 1948, Dr. Robinson is the first to use a manometer to measure the pressure in the brain. That's 70 years ago. That's not long ago at all. And then in 1965, Dr. Lundberg connects it to a strain gauge monitor for ventriculostomy. In 1987, of course, Richard, I was already practicing, right? Richard publishes ICP via fiber optic device. So what we think of as the cornerstone of intracranial pressure, we say Monroe Keely doctrine. It's not. It is actually the Hippocrates, Gailey, Monroe, Abercrombie, Keely, Magendie, Swedenborg, Burrows, Keene, Cushing, Robinson, Lundberg hypothesis. It's never been proven, and it is mostly based on two dead sailors who washed ashore in November of 1821. Not a good foundation for what we're studying. All right. So if Dr. Olson's not big on the intracranial pressure, why am I studying it so much? Well, because nurses should study intracranial pressure. And we have. But you probably haven't seen it. A lot of the nursing research doesn't get the press that I think it deserves. We study pressure because we're studying pressure monitoring. If you are a nurse, you should be proud of this and you should work with us. If you are a physician, you should care about this, because if I tell you the pressure is 15, but it's really 5, that's not good information. You want to know the truth. Let's look at some of these examples. Study from 2011. Cerebral spinal fluid drainage doesn't work like we thought it did. 2015. The numbers we put in the medical record are not the numbers we think they are. They're not reliable. So when we drain cerebral spinal fluid, we're not doing what we think we're doing. And when we write down that the ICP is 12, it turns out we're not really very sure of that number. There's also huge differences. This was a global survey in how we think it should work. If you ask people in Colombia and people in the United States and people in Canada and people in Europe and people in Australia, they all give you different answers as to how we should monitor ICP. We followed this up with a 2013 study. There's huge differences in the United States. We looked at 4 U.S. hospitals. All 4 hospitals did it differently. And at each hospital, they did it differently. If Dr. Smith was on, you did it one way. If Dr. Jones was on, you did it another way. We're not doing anything the same at all. Nothing is the same. If you look at where we monitor brain pressure, if you monitor it here, it's different from here. If you monitor it in the ventricle, EVD, it's different than in a bolt, intraparenchymal. If you have a lesion on the left side and you monitor on the right side, you get a different value than if you would have monitored it on the left side. It's not just intracranial pressure, it's cerebral perfusion pressure. because cerebral perfusion pressure is calculated from blood pressure and intracranial pressure. And if you measure the blood pressure in this arm, it's different than in this arm. If you put an art line here, it's different than a cuff here. It's different than an art line here. Everything is different. So going by cerebral perfusion pressure gives you wild, like 40 points difference. ICP is dynamic. This is not a hard one. You know this. If you watch ICP, it's not like 8, It's like 8, 10, 6, 14, 13, 12, 1, 17. It's very dynamic. We also found that a lot of things happen. If your patient goes to radiology, if they go for an intervention, there's a lot of stuff that happens in the EVD during transport. This is a reinforcement of the study that I mentioned before. This was another follow-up. The ICP in the ventricle, if you look at a ventricular pressure and a parenchymal pressure at the same time, 2 different values. If your patient is laying flat, the ICP is different than if their head is up. If you measure it with their head up and they're on their back, you get a different number than if their head up is on, and they're laying on their side. And that's because everyone reads it differently. If my ICP is, like I said, going 8, 10, 12, 14, 17, 1, 6, 9, 3, which number do you take and when? What number is the one number for the ICP? We do not know the answer to that. No one on this planet knows the correct answer. Everyone thinks they know the correct answer, but everybody has a different answer. We don't know the best way to get rid of the EVD. There's continued research going forward. Fundamentally, these are important nursing questions. A neurosurgeon puts in the brain pressure monitor, and then the nurse takes over, and no one knows how to tell me the right way to do it because there is not a right way to do this. Look at this picture with all the heads. Where do you put the transducer? If you ask a physician, they say you level it to the tragus, to their tragus, right? Well, do you level it to this tragus, the right tragus, or the left tragus? Because they're different. Those pressures are different. If the patient's laying flat on their back, the foramen of Monroe is in a different relation to the tip of the ear or the outer canthus or the tragus or a point in between than if the patient's sitting up. When do you chart it? If you look at this chart, this is only 400. This is like 4.5 seconds, 450 hertz. This is a short period of time. 1, 2, 3, 4, 5, 6 heartbeats, where the ICP could be 13, 16, 19, or 22, depending on how you read it. And if you think there's no difference, there is. If I tell you the ICP is 22 and I tell you the ICP is 13, you have fundamentally different responses. Nursing is the one profession that will give you that information. Nurses need to be involved in studying this because no one else will. We're the ones who are doing it. We need to study it. So my answer to the importance of the nursing role in the management of traumatic brain injury is that we as nurses control the environment of care. We set the stage. We determine how accurate the information is that the physician will get. If I give you bad information, as a physician, you cannot make a good decision. If you as a nurse, if the other nurses in the audience, if we give bad information, the physician cannot make a decision, a good decision. Doctors, physicians, they're not going to study this. It has to be the nurses. And I think all of us as nurses, we should be encouraged. We should be conducting these large international trials to solidify how nursing contributes to patient outcomes with traumatic brain injury. I'm going to stop here, and I am available for questions. I'm also available if you send me an email, and this is my email. I love hearing from other people, so please share your thoughts.